Thanks, Dr. Goldenberg. Good morning. Good morning to any distant sites that are tuning in. I understand Dr. Melnick from the island is gracing us with her telepresence. So I'll be speaking on GU cancer survivorship, and the objectives were circulated earlier, and essentially to define survivorship, talk about some of the reasons that make this an important discussion, emphasize some of the unique aspects from a genitourinary point of view, from a urology point of view, identify barriers to programs and areas that need further research, and to demonstrate the role of the urologist here. So it's not the strongest of the species that survives, nor the most intelligent that survives. It is the one that is most adaptable to change. I think this is a relevant quote for two reasons. One, from the perspective of the patient being diagnosed with cancer and then subsequently having to undergo treatment. It's an enormous period of change for them. And from the urologist's point of view, we have to be willing to understand those challenges and also adapt our own practices to meet their needs as best we can by adopting new care strategies as they become available. So one thing I was surprised is that some people were pretty unfamiliar with the topic of survivorship, so I thought I'd briefly talk about what survivorship is not. I initially thought this was a department picture from 1980, but I didn't recognize anyone. Haircuts are a bit different. So survivorship is not the band in 1982 that made the Eye of the Tiger for Rocky III. It's not the TV show that runs perennially and is on again this year. And although I wish we had more time to talk about Beyonce, it's not Destiny's Child.
Wait, go back.
So, a cancer survivor is any individual from that point of diagnosis to for the remainder of their life, and it's a broad definition that captures various cancer types, treatments, side effects, disease, whether it be indolent or aggressive, localized or metastatic. And some people feel that this can be lumped in with terms such as supportive care, psychosocial oncology, quality of life research, or integrated care. But I think these terms really fail to capture the comprehensiveness of survivorship as a topic. And so I wouldn't say that these are synonyms of survivorship rather than parts of survivorship. So survivorship has been around for a long time, but it really didn't come into its own until it hit the spotlight in 2005 in the landmark paper by the Institute of Medicine, which recognized significant shortcomings in the care for the 10 million plus cancer survivors in the States. And from this, they made goals to highlight the consequences of cancer and its treatment, define what quality care was for these people, and means to achieve this, and the lofty goal to improve quality of life for these people. And in this paper, they defined survivorship care as the phase of care following primary treatment. And I put some asterisks here because I feel that this definition should probably be expanded, and there's some groups that we'll see that would agree with this. But traditionally, it's been defined to have four components, being prevention for new or recurrent cancers and comorbid disease, surveillance for cancer progression, recurrence, or secondary cancers, intervention once those consequences arise, and importantly, the coordination of a healthcare team that can address all of the patients, all of the survivors' needs. And I think it's important, and we'll give emphasis that the caregivers should really be recognized in this plan. So this would be the model that I've just described, and I think this model from the Survivorship Action Partnership from the Prostate Cancer Canada website probably gives a better definition of what survivorship should include. You can see that it actually begins at the time of diagnosis and follows the patient through all phases of their care to the end of their life. So why do we care? Well, the number of survivors is increasing and will continue to do so. Survivors are living longer, they face unique issues, and these issues require expertise from a number of different specialists. This figure shows the rising number of survivors in the United States. In the early 70s, you had about 3 million, and as of January this year, they projected that we had about 13.7 million. And as urologists, we can see that our survivors are well represented, as approximately a quarter of these survivors are represented by urologic cancers. Looking more closely at the most common urologic cancers, prostate, bladder, and kidney, we see that the majority of patients fall between ages of 65 to 85, and that, not surprisingly, the majority of these patients are comprised of prostate cancer survivors. Now, penile and testis cancer aren't addressed in this table, but obviously, when one thinks of their treatment, they have unique considerations for survivorship care. And unfortunately, we can't talk about all GU cancers today. It's a bit of a busy slide, but essentially the take-home message is that survivorship has improved over 3 different eras in treatment. For all comers, we're looking at 5-year relative survival in over 65%. And if we look at prostate cancer, we can see that for local and regional disease, your 5-year cancer-specific survival is about 100%. So we've made some significant gains here. In Canada, we have about 1 million survivors. About 1/5 of those are represented in BC. Again, we can see that the 5-year overall survival for all comers is greater than 60%, but it's significantly higher for cancer-specific 5-year survival, significantly higher for those of major urologic cancers, and again, prostate cancer is on the top of that list. And survivorship is growing. The number of survivors grows by 2.5% every year. We have 500 Canadians diagnosed every day, and just 200 are dying from their cancer. And approximately 40% of men and women will face a diagnosis of cancer at some point in their life. The table at the bottom illustrates that as urologists, there doesn't appear that there'll be any shortage of work coming up. The economic cost of cancer is astronomical. I was unable to find any kind of further breakdown of our healthcare expenditure in Canada on cancer since 1998, but at that point we were spending $17 billion in total cost, over $4 billion in direct costs. And to put that in perspective, at that time our total healthcare expenditure was about $100 billion per year, and as of 2010 we were approaching $200 billion. So one can imagine how these numbers have grown since then. In the United States, obviously the costs are much higher. They're spending over $124 billion, and urology is making up about 15% of this. And this doesn't include the unmeasured costs to patients and caregivers, or for those less common cancers like penile or testis cancer. So there are a few things that make some of the more common GU cancers especially costly. So for prostate cancer, we have men who have prolonged survival. There are a number of late effects to treatment that we're familiar with. Androgen deprivation therapy has its own list of downstream consequences on overall health, like bone health, cardiovascular health, emotional health. And the introduction of novel agents for castrate-resistant prostate cancer are adding significant cost to the care of these patients. Bladder cancer has been cited as one of the most expensive cancers from diagnosis to death. With kidney cancer, we have a rising incidence of small renal masses, often in young patients that present their own kind of surveillance and management concerns. And as Dr. McNeely's fond of calling them, these patients represent victims of modern imaging technology or vomits. So because of the prolonged survival, many people feel that the diagnosis of cancer, especially with genitourinary cancer, for many people has become almost like a diagnosis for a chronic disease. However, there's some specific differences that should be recognized compared to their non-cancer control counterparts, and this is that they've been recognized to have lower health status, a greater number of comorbid disease. They have significant issues relating to their body image, sexual function. They face unique issues with insurance and financial hardship. And there's also some significant changes in their personal relationships. Furthermore to this, the treatment of cancer is unlike that for chronic disease in that it's often more complex. It's often multimodal, multidisciplinary. It can be quite toxic, expensive, disruptive. We face problems in coordinating cancer care appropriately, and it happens aside from the family doctor, and we often don't do enough communicating with the family doctor or the primary care team. And we have poorly defined provider roles for who's taking care of what aspects of cancer care with these patients. So how do we get here where we're now lumping cancer in with chronic disease? Well, earlier detections, novel pharmacotherapies and treatments, multimodal therapies, the adoption of evidence-based practices and guidelines, adjuvant, neoadjuvant care, and kind of looking after the patient more in terms of their overall health and prevention of their secondary malignancies. So survivorship really comes, and our strides we've made really comes with a trade-off in terms of a number of domains: time, money, human interpersonal costs. And I think when we're talking about these costs, it's important to give focus to, at least today we will give focus to two areas in particular. One would be fragmentation of care, which strongly impacts time and money in the care of these patients. And another area will be addressing the human interpersonal costs, kind of at the level of the partner or caregiver. So to begin by talking about fragmentation of care, on the left-hand side, if you picture these pie charts as the overall care for a patient, the one on the left represents a high amount of fragmented care, and the pie chart on the right is a lower fragmentation of care. And this basically represents almost like a market share for who's caring for the patient. This is the degree which cancer care is dispersed over a number of providers. Now, you obviously need some fragmentation or collaboration in order to present a number of therapeutic options and manage complicated disease. But you can see that if one person is kind of taking point for the majority of care, this represents a lower fragmentation. And in Scalara's paper in 2012, they looked at 67,000 prostate cancer survivors from the United States, and what they found was that fragmented care was higher among those who had higher socioeconomic status, those Caucasian patients and those young patients, and that this care was 3 times more expensive and often had duplicated investigations. Now, it's interesting that they did find that these survivors had higher survivorship interventions, proceeding with androgen deprivation therapy or receiving prostheses. They had longer follow-up, but it's not clear if this had any impact on survival. Fortunately, previous research has demonstrated that fragmented care is associated with a decreased quality of life, decreased quality of care, increased cost, and poor outcomes. And prostate cancer survivors are especially at risk for this fragmented care, based on the number of treatment options they have, their prolonged survival, the number of late effects that they face from treatment, and the subsequent interventions they undergo for these treatments. So they can be their care can really be split up. There are some ideas for overcoming fragmentation, and these focus mostly on communication, clearly defining provider rules, the adoption of electronic medical records, and importantly, the creation of an integrated delivery system. So this is really not unlike what one would expect within a survivorship program. This is an organized, coordinated, collaborative network of healthcare providers that provide coordinated care for the patient in a vertical continuum, meaning patients can easily be slotted into any area of expertise they know, in a manner that is easy to link between providers. And this is a system that's clinically and fiscally accountable, and like I mentioned, these are common goals to a survivorship program. So, from fragmentation to elephants, transition and talk a bit about the actual elephant in the room here. As urologists, we're familiar with the physical and emotional effects of our surgery, radiation, chemotherapy. I don't think I need to go over the late effects for the group here. But what we often fail to acknowledge is the impact that this has on the caregiver or partner, and they literally are the elephant in the room when we're talking to the patient, and they're often ignored. It's not a surprise one doesn't cope with cancer in isolation. Family members often shift their role into caregiver positions, and this carries significant burden. Stress during prostate cancer has found to be potentially even greater for the patient's caregiver than for the patient themselves. And what I thought was surprising, that 13% of caregivers to those patients with advanced cancer meet the criteria for a psychiatric disorder. They have decreased quality of life, and they experience significant hardship in terms of their financial situation. And we know that we can make very kind of impactful improvements here for survivors with very little effort. And so this seems like a worthwhile area to address if we knew how. Like I mentioned, the impact of what we put our patients through really can't be understated for the effects on the patient and partner. They're dealing with incontinence and urinary bowel symptoms, changes in libido and sexual function. We're removing body parts and sometimes adding new body parts, and this places enormous stress on the partner, the patient, and their relationship. We know that partners play a critical role not just in their sexual recovery but also the overall recovery. And without help, many partners will buffer these types of difficult uncomfortable discussions out of their conversation, which is kind of a discordant adaptive strategy and creates distance in the relationship and a loss of emotional or sexual intimacy. We know that we have to address these forms of loss with both the patient and the partner if we want to prevent long-term dysfunction. There's an interesting paper from Kim's group in 2008 where they looked at 85 prostate cancer survivor couples and 85 breast cancer survivor couples. And what they found was that survivors and their caregivers experienced similar levels of distress and diminishment in quality of life. But this wasn't a two-way street, and it wasn't equal between men and women. Female spouses tended to suffer greater psychological distress and mental health issues versus their male partners, and this was especially true if you had the stoic John Wayne type of male partner who didn't really voice his emotions that well. And this created feelings of isolation in the female partner, that they were an inadequate partner, that they had been emotionally abandoned. And I think the most important part about this slide is that the distress in the female spouse actually predicted men's physical health more so than the man's level of distress, more so than his age, and more than his cancer stage. So there's some really important information to recognize how much of an influence the partners and caregivers have here. So now that we've talked about what survivorship is, we've talked about its importance, some of the costs, we can transition and talk about some of the areas we're able to target during their treatment. And as Dr. Goldenberg alluded to, really care begins before primary treatment, just following the time of diagnosis. And when we're at this point, there are two things that we might be able to offer patients. One is setting realistic expectations for them to minimize regret down the road for their choice of treatments. And a second area is potentially considering whether or not a prehabilitation program would be beneficial. So in life, our expectations are often different than what happens in reality. The same is true for treatment of GU cancers. Our treatments have a profound impact on patients, and we have to find a way to set realistic expectations for our patients, thereby minimizing regret. And we know that regret is an important factor when considering overall treatment outcome, and we know that we can minimize this beforehand by use of patient and partner education. Lack of patient involvement in treatment decisions has been a strong factor linked to patient regret. In the publication by Dennis's group in 2011, they looked at over 300 specialists and 50 patients to kind of determine their practice pattern, and found that these physicians, for the most part, were spending about 15 to 30 minutes discussing the diagnosis of cancer, and then a subsequent 15 to 30 minutes discussing the treatment. And this was deemed insufficient by nearly half the patients. It seems like a fairly substantial amount of time, actually, to me. There's also a disconnect between what information was discussed and what level of comprehension was attained. And overall, physicians scored quite poorly in terms of having their patients rate them as sensitive or supportive of their situation. And the problem was highlighted whether this was a lack of skill or a lack of time. But I think what this highlights is that a possible solution for this is, rather than asking the urologist to take more time in his office, this may play more or argue more to the fact that we should have a centralized or standardized education program that can utilize individual characteristics of patient disease so that patients can make informed decisions rather than placing this burden back on the urologist. I think this would streamline our care and provide more information to the patient that they find useful. So in this group, by some authors you may recognize in the room here, they looked at kind of the effects of sexual function regret 1 year out from treatment with radical prostatectomy for localized prostate cancer. And they found that in spite of the significant side effects that patients faced, and there were significant side effects, few men regretted their decision for surgery at 1 year. And the rationale for this was that the patients had been informed of the side effects and involved in their treatment decisions. And this has been supported by other authors as well. Interestingly, they found that patients who had higher levels of regret, this tended to correlate to patients who had a greater change in their quality of life, had reduced social functioning as a result of the treatment, experienced more pain, or had more financial difficulties. And it's important to recognize that these are all aspects of care that would be addressed in a survivorship program and provide an opportunity to improve our treatment outcomes. Somewhat contrary to the last slide that I've just shown you, Whitman's group in 2011 found that when they looked at patients after prostatectomy, their level of expectations were kind of out of line. Now, they took patients and they put them through a standardized education program with a urologist, a nurse clinician, and a sexual therapist, and this was a standardized approach. So they really educated patients. In spite of this, they found that patients still kind of their expectations were out of line with reality. And they found that even 15% of men felt their erections and continence would improve after a radical prostatectomy. And they put out a number of ideas for why this might be. One was whether this was marketing of the robot and the robot treatment, or whether this was just kind of a maladaptive coping strategy to cope with a loss in those patients. But I think this still highlights a couple of areas of need that these patients and these couples need ongoing care, and this would be best addressed in the survivorship program. And that we need further research to determine what's the optimal way to transfer information to patients so that they can make realistic expectations prior to surgery. The other area that I mentioned we can target potentially before primary treatment would be prehabilitation. This is gained ground in some other areas of surgery. Mayo's group in 2011 looked at this in patients undergoing colorectal surgery, and they assigned patients either to routine care, cycling and resistance exercises, or walking and breathing exercises. And what they found was that a 3 to 8 week prehab program can offer benefits to the patient, mostly in terms of quality of life, mental health, perceived health status, but there is some cardiorespiratory improvements as well. Unfortunately, this didn't translate into reduced complications or hospital stay, which is what most people would really want to see. But I think the results do support that a prehab program, they had greatest benefit with walking and breathing, might be one area where we can serve our patients better before primary treatment. And one area in GU cancer specifically might be androgen deprivation therapy, where men are facing significant changes in their mental health and physical composition and face significant comorbid disease down the road with bone health and cardiovascular health. So we've talked about what we can do before primary treatment, and we can discuss a little bit more what would fit in the traditional definition of survivorship care. And again, this happens after primary treatment, and according to the kind of 4 principles of prevention, surveillance, intervention, and coordinated care. And when we're talking about this type of care, I think it's important that we talk about the importance of having a treatment summary and a care plan for these patients. And what these tools provide is basically a method of directing, coordinated, efficient follow-up care that ideally happens according to clinical guidelines. It should summarize the treatments, the providers, the disease characteristics, whether stage and grade, notable findings like surgical margins. It should describe to the patients and other providers the late effects of treatment and future care needs that will need to be addressed. It should clearly define who's responsible for what aspects of care and following up with this patient. What the goal would be to prevent fragmentation, and minimize cost here as the patient move between sites and providers in their survivorship care, and ultimately also empower the survivor with their own care so that they can make better choices in terms of their lifestyle of diet and exercise. So these are really important tools. Now, the next slide, I don't want anyone to try and see what this is. This is for breast cancer, and it's a care plan made by the American Society of Clinical Oncology. And I'm just going to summarize. There's only 4 things we need to see on this sheet. For this care plan for breast cancer, it says what's going to be followed up. And this isn't a long document. It's about 1 or 2 pages that the patient has with them. It's electronic. It's circulated. It's what the patient's going to follow up with. Why are we following up with this? Who is going to do this? Who is responsible for carrying this out? And how often is this going to happen? So some fairly simple information, but that's often lost in translation as patients move through. The second page details, like I've said, is important. The late effects of treatment, who is at risk, what the level of risk is for these late effects, and just in general, what we might do if these consequences occur. So unfortunately for genitourinary cancers, neither has been specifically developed. They've been developed for some of the other cancers that I've mentioned here. patients can make their own, but they lack specificity. But if we were to make one for prostate cancer, it might detail obviously the provider roles, the unique side effects, schedule of physical exams and investigations like PSA. It would have resources for psychosocial and sexual health, and it would recognize partner needs as well. And wellness plans have also come into the area of survivorship, and I won't spend long talking about it, but I think as urologists providing or delivering diagnoses, we're in unique positions to use this point in time as a teachable moment. And it's been shown that we can make this is one strategy for kind of making significant improvements to the patient's overall quality of life. I think the importance of this is highlighted by some of the information in prostate cancer. We see that cardiovascular disease is actually the major cause of deaths in prostate cancer survivors, and that men who exercise vigorously for greater than 3 hours a week reduce not just their overall mortality, but also their cancer-specific mortality. So the future of survivorship really comes down to addressing some of the areas of need, and this is determining what optimal follow-up is for these patients, determining what's the best surveillance regime for these patients, defining care provider roles, which you've heard me say a number of times, creating specific treatment plans and summaries for GU cancer survivors, finding the capital initially to invest in these programs, which is a huge task and requires a lot of money, but with the understanding that this money comes back to itself in terms of saving costs for fragmentation. Integrating all the medical records we have for patients will be a huge challenge, coordinating all the different specialties and linking them in a way that is easy for referral. And most importantly, we have to create this in a system that can be audited or interrogated so that we can look back and determine whether or not objectively we've provided benefit here. So we're getting to the end of the discussion here, and I just want to highlight one of the novel programs that's happening right here at home for prostate cancer survivorship. This is an initiative in progress, as Dr. Goldenberg just touched on as we started here, by Dr. Goldenberg, Dr. Bebb, Dr. Ehrlich, and Dr. Wassersug with various other partners here to provide a survivorship program right here at home. And the idea is that this would be a centralized program that would roll out in phases. It has a program coordinator at the center of it to oversee the running, and it would utilize existing resources and adopt kind of integrated care to improve quality of life. And the hope is that this program can be validated here and then disseminated to regional centers across BC so that patients can access this without having to live directly in the Lower Mainland. And this really came from the acknowledgement of the issues that we've talked about already, unique to prostate cancer survivors and GU cancer survivors, and appreciating that they live much longer than they did 20 years ago. They're often diagnosed much younger than they were in the past, and we're treating them while they're asymptomatic, but our treatments have significant side effects on both them and their partners. And you can appreciate that addressing all the issues that these patients have requires an enormous amount of expertise from a number of different areas, and the urologist is just kind of an important cog in this machinery. So to conclude, the diagnostic and therapeutic advances have dramatically improved the number of people living with cancer. GU cancers face unique challenges and are best cared for by a coordinated team. And I think it's important that as urologists we not feel that we have to care for each sequelae of treatment or late effect that happens, but be aware of these and have access to a system where these patients can be referred for expert care. I think in doing so, this actually streamlines our practice and makes us more efficient and provides increased quality of care for the patient. We have to remember the partner when we're dealing with people in survivorship positions, and we obviously need more research to determine optimal survivorship care for GU cancers. So I'd like to thank Dr. Wassersug for looking over the slides for this and helping me with some of the content here, and thank you for listening and take any questions if there's any.